So let's start today's webinar.
Yes, thank you very much.
Yes.
Okay, we can start, please.
こんばんは、先生。
こんばんは。お元気ですか？はい、
や
原住。
Hello, hello. こんばんは。
こんばんは。はい、Dr. Hui?
Hello, Karo sensei.
はい、はい。
How are you doing?
When do you go to Nakai sensei, please?
I'm working with the hospital director on the Times Square.
Okay.
Yeah.
Sensei,
Okay.
please start.
So let's start today's webinar. Yeah, good evening, ladies and gentlemen. I'm Takehiro Uda from Osaka Metropolitan University, Japan. And welcome to this ACNS ISMINS webinar. Before introducing today's speaker, I'd like to share a brief one-point session as the chair of this webinar. The title of this short introduction is Recent Trends of Epilepsy Surgery. Neurosurgery consists of a wide range of subspecialties, including vascular, tumor, trauma, functional, and spine. In today's webinar, we invited two speakers. One is Professor Khoo from Malaysia, and the other speaker is Professor Hyun-sung Kim from South Korea. Both of them are leaders in their subspecialties. In the first presentation, Professor Khoo will talk about SEEG, stereotactic EEG in epilepsy surgery. Let us briefly look at the historical background of epilepsy surgery. In 1924, Penfield established the concept of functional cortical localization. During the 1950s and 1960s, advances in neurophysiology further clarified eloquent brain areas. After that, conventional epilepsy surgery was established. At that time, epilepsy surgeons mainly performed temporal lobectomy for major temporal lobe epilepsy and corpus calostomy for patients with generalized seizure patterns. Later, several functional preserving surgical techniques were developed. Dr. Morel invented MST, multiple subpial transection, which transects the cortex by scratching rather than dissection in order to avoid the damage to the eloquent areas. Dr. Yasargil introduced a transfusion selective amygdala hippocamectomy. That is a microsurgical technique aiming to preserve the lateral temporal neocortex. In addition, Dr. Shimizu in Japan developed the hippocampal transection to preserve memory function for major temporal lobe epilepsy. The concept of these surgeries was not maximum resection, but maximal seizure control with minimal functional impairment. A major paradigm shift occurred with the introduction of VNS, vagal nerve stimulation. That surgery is the first generation of neuromodulation, seizure reduction without cortical resection. This approach expanded surgical options for patients who are not ideal candidates for resective surgery. In 2010, stereotactic EEG dramatically changed epilepsy surgery. SEEG enables three-dimensional network-based evaluation for epileptogenic areas. It also made possible radiofrequency thermocoagulation or laser ablation therapy. As a result, epilepsy surgery became significantly less invasive. More recently, DBS and RNS have emerged as a second-generation neuromodulation therapies. Currently, the main DBS targets are the anterior thalamic nucleus for focal onset seizures and the central median nucleus for generalized onset seizures. And RNS is a new concept of stimulation. It is a closed loop system. That is stimulation is delivered only after abnormal activity is detected. These techniques focus on modifying pathological neural networks rather than removing brain tissue. Epilepsy surgery is now evolving from resective surgery to regulatory surgery. In the second presentation, Professor Hyun-sung Kim will give us a lecture on endoscopic spinal surgery. A big trend toward minimally invasive surgery is not unique to epilepsy surgery. In spine surgery, endoscopic techniques are considered effective because of their lower invasiveness. Several endoscopic techniques have been reported. That is one of the examples. In a study published in 2019, the authors compared microsurgery, biportal endoscopic surgery, and uniportal endoscopic surgery for lumbar central stenosis. According to their results, although dural expansion was similar in the uniportal group, but postoperative back pain on day 1 was significantly lower in the endoscopic groups. In a more recent report focusing on elderly patients with lumbar spinal stenosis, both uniportal and biportal decompression showed a significant pain reduction and a functional improvement in daily activities. I'm not a spine surgeon, but I'm very interested in these new techniques. The goal of epilepsy surgery is not only a good seizure control, but also a good intellectual outcomes and social outcomes. Similarly, the goal of spine surgery is to improve the patient quality of life. The essence of modern neurosurgery is not simply less invasive. The important is to choose the optimal balance between the invasiveness and efficacy for each patient. Dissection, disconnection, and neuromodulation are no longer competing concepts, but complementary tools. I'm very much looking forward to listening to lectures from both speakers. So let's move on to the first lecture. Professor Khoo from Malaysia and Osaka. Please start your lecture, please.
Okay, thank you, Dr. Uda. Let me share my screen. There. So yeah, I'd like to thank Dr. Kato and Dr. Uda and the committee for offering me this the chance to speak here. Can you hear me well?
Yeah, very well. Please.
Okay,
Start.
thank you. Okay, today I'll like Dr. Uda has given us some introduction. I will give a brief introduction to stereo-electroencephalography, SEEG, as a minimally invasive method for a delineation of epileptogenic zone in drug-resistant epilepsy. So the standard care of patients with epilepsy starts with anti-seizure medication. The epilepsy surgery should be considered as soon as possible once they fail to anti-seizure medication. Curative surgery, such as focus resection and ablation, are effective surgical options to those with drug-resistant focal epilepsy. However, epileptogenic zone needs to be localized before this kind of curative surgery can be offered. First, we try to delineate the epileptogenic zone non-invasively using tests in the phase 1 study. If there are some concordance, but there are still some doubt or data insufficient for surgical decision, a phase 2 invasive study using intracranial EEG monitoring is indicated. Intracranial EEG using subdural grids and SEEG are the two main modalities for invasive studies in epilepsy. I believe subdural grids, which require craniotomy, has been the mainstay in most of the epilepsy centers in Asia until recently. Today, we will have a closer look into SEEG and the less invasive modality that does not require craniotomy. SEEG was developed in France in the 50s, much earlier than subdural grids was first developed in the USA. Its utility remained confined to France, Italy, Spain, and Montreal, Canada for more than 50 years until it was accepted in the USA around 2009. Since then, it's seeing an abrupt increase in its use worldwide. SEEG involved the use of intracerebral electrodes that were inserted through a small craniostomy. However, SEEG is not the technique of inserting the electrodes per se. It is the method to confirm or to refute the hypothesis generated to delineate the epileptogenic zone from the sum of non-invasive workup. Moreover, we also need to keep in mind that SEEG electrodes can measure not only the target, but all along the trajectory. What about the indication? According to the IOE consensus, the indications are the same across methods for invasive study. It is indicated when localization and delineation of the extent of the seizure onset zone and when mapping the equiloquent cortex is necessary. In a nutshell, SEEG is indicated when localization or lateralization is insufficient from the non-invasive data. SEEG is especially useful when dealing with deep targets and when bilateral exploration is needed. However, it does not support mapping of contiguous cortical surface and is less suitable for those below 2 to 3 years old because of the thin skull. Compared to subdural grid study, SEEG is less invasive, and patients who underwent SEEG complain of little or almost no discomfort throughout the recording that typically lasts for 1 or 2 weeks. SEEG is especially useful for exploring seizures involving the deep structures that is less suitable for subdural electrode study. Seizures originating in the orbicular insula region and the cingulate cannot be sufficiently studied without SEEG because the area of SEEG electrode implantation is not restricted by craniotomy. Epilepsy associated with multiple lesions such as tuberous sclerosis, nodular heterotopia, and those required bilateral implantation are also good indication. Bottom of sulcus dysplasia is another case that SEEG is useful. We won't be able to see the EEG abnormality in this, like we can see here, if we are monitoring only the surface, as shown in this ray tracing. Adhesion is always an issue in patients who have undergone prior craniotomy, and this often hinders the neurosurgeons from reopening for another invasive study. SEEG appear to be safe and effective in patients with prior craniotomy. Therefore, evaluation of surgical failure is another good indication for SEEG. There are a few important points that needs to be taken into account in this hypothesis construction and electrode placement for SEEG. First of all, we should understand that each electrode contact samples only a very small area, which is different from the case of scalp EEG. In addition, the amplitude of a signal is inversely related to the square of distance from the generator. Therefore, signal attenuates very quickly with distance. So we may not see an epileptic activity even we are just a centimeter away from the generator, like what we have seen in the case of bottom of sulcus dysplasia. Indeed, SEEG samples only 1% of the brain volume. Therefore, it's very important to have a strong hypothesis because the regions of implantation relies heavily on the hypothesis. SEEG electrodes needs to be placed according to an exploration plan such that they can obtain sufficient electroclinical information during spontaneous seizures based on the anatomo electroclinical correlations. The plan has to be constructed so that it can answer the question, can the spatial temporal organization of the epileptic discharges that involves a certain combination of anatomical regions explain the chronological occurrence of a seizure semiology. The information for these three components are obtained from the semiology, including the aura, scalp, EEG, and imaging studies. Source localization methods such as simultaneous EEG, fMRI, and MEG are also good guide for SEEG planning. As a rule of thumb, a clear hypothesis should always precede the implantation, and exploration should be based on one main working hypothesis. The implantation should target the presumed seizure onset and the early propagation zone. Placement of electrode in the eloquent area is doable, but should always be minimized or avoided if not crucial in the interpretation. Typical SEEG implantation usually requires 7 to 14 electrodes. Fewer than 6 indicates that SEEG may not be necessary. More than 15 indicates possible fishing expedition. Let's take a look at the surgical aspect of SEEG. Frame-based technique, initially developed by Talairak, has been widely used for at least 30 years until the invention of neuronavigation. Following the introduction of neuronavigation in the 2000s, various frameless devices were developed and adapted for SEEG electrode implantation. The advance in robotic technology have further enhanced the development of frameless technique. Nowadays, SEEG electrodes are inserted under general anesthesia using either a frame-based or a frameless technique depending on the local availability of these tools. Here are the two videos of SEEG electrode implantation performed at our hospital, robotic assisted on the left and frame-based implantation on the right. While trajectories are automatically set in robotic assisted procedure, frame-based implantation is more labor demanding and time consuming as manual adjustment of coordinates and angle is necessary. Otherwise, the surgical technique involving craniostomy using a twist drill, insertion of electrode into the tract created using an actuator, fixation of electrodes are similar between the two procedures. As an SEEG study usually requires implantation of 7 to 10 electrodes on average. Robotic assisted surgery can be time-saving. Fixation of electrode on the skull using a hollow anchoring screw, also called the anchor bolt, is the standard practice. Boltless method has been standard in Japan because anchor bolt has not been approved until last year. This method offers an acceptable accuracy and is useful in electrode implantation in the occipital lobe and in those with thin skull like children. There are technical considerations that we need to be aware of during the planning of trajectories. First, the trajectory should be at least 2.5 millimeter away, especially from vessels on cortical surface to prevent hemorrhagic complication. This margin should be adjusted to fit the implantation accuracy of each hospital. Secondly, the insertion angle relative to the skull should be less than 30 degrees to prevent skiving of the drill. Frameless technique, including robotic, allows us to omit the stereotactic frame and thus CT acquisition after frame fixation during the procedure. The main purpose of all these modern devices is to ensure a fast and yet precise insertion of the electrodes. The accuracy using robotic assisted frameless technique is similar to that of the frame-based technique. Neuronavigation guided frameless technique has also been utilized for SEEG electrode implantation, but with a less optimal accuracy. Generally, frame-based technique appear to be more time-consuming compared to frameless technique. I think it is also worth to mention some diagnostic adjunct as well. Although SEEG is less well adapted for functional mapping continuously on the superficial cortex, it is sufficient for delimiting the eloquent cortex from epileptogenic zone for the purpose of resection planning. A few studies comparing electrical stimulation using SEEG electrode with fMRI functional map show that can reliably identify speech area and valid for sensory motor mapping. Speech-induced high gamma activity can be used for selecting stimulation sites in speech mapping. Electrical stimulation through the implanted SEEG electrode is used to induce seizure to complement the findings of spontaneous intrarectal and ictal SEEG recording. Some stimulation-induced seizures were shown to be as reliable as spontaneous seizures in delineating the seizure onset zone. Stimulation-induced as seizure onset zone is defined by electrode contacts that evoke clinical findings mimicking the early manifestation of a typical seizure when stimulated. Radiofrequency thermocoagulation can be performed at the end of SEEG study through the already implanted electrodes without requiring an additional implantation. Because the lesions created using this method are usually relatively small, it has been treated as a diagnostic tool to predict the seizure outcome of resecting the SEEG to find seizure onset zone. According to the French experience, patients with favorable initial thermocoagulation outcome tend to have a favorable surgical outcome after a subsequent resection. Recent meta-analysis show that 70% of the patients who underwent RFTC remain to be responder and 38% remain seizure-free at 1 year follow-up. So SEEG-guided RFTC is not only diagnostic, indeed it is therapeutic. So what is the outcome? Here is a summary of seizure outcome from SEEG-guided surgery. The seizure freedom rate at last follow-up falls between 55 to 76%. And international studies show that SEEG has a lower odds of subsequent resective surgery, while the odds of seizure freedom was 1.7 times higher, and the odds of complication was lower for SEEG. Our hospital has adopted SEEG since 2019, and SEEG is slowly replacing subdural grids. This provided us a chance to compare the two modalities. In our hospital, 67% of patients who undergone SEEG proceeded to curative surgery. 80% of those who undergone curative surgery have a favorable outcome. Compared to subdural electrode studies, the seizure-free rate remains higher over time in SEEG. Compared to subdural grid study, the SEEG study is less painful. Patient underwent SEEG use less N6, and appetite resumed faster after electrode implantation. A less painful and a less discomfort experience throughout the monitoring may reduce patient reluctance in undergoing epilepsy surgery. Minimally invasive SEEG should lower the barrier to epilepsy surgery and thus improve the underuse of surgery among pharmacoresistant epilepsy. SEEG may also improve the outcome of curative surgery. I'd like to take this opportunity to express my gratitude to our team and my mentors who are indispensable in the development of SEEG at our hospital. Thank you for your attention.
Thank you very much, Professor Khoo. Okay, does anyone has questions or comments, please? Yes, please, Dr. Nake.
Thank you very much. Very nice presentation. My name is Hyun-sung Nakai from Fujita Health University Department of Neurosurgery. I thought you mentioned that trajectory of SEEG should be kept below 30 degrees. Is there any study or evidence supporting that? Because in some cases, sometimes we want to more incline. So how come the 30 degrees is important?
Yeah, well, yes, there are a few studies looking at the insertion angle. So if we have like more than 30 degrees, usually it's easy for the drill to skive. So once the drill skive at the skull, it means we'll have you'll get a huge like big just a small angle, you'll get a huge displacement from the original target, and it can be quite dangerous. So there are a few studies looking at that, and apparently, as a conclusion, it is shown that 30 degrees is kind of a limit. There are some well, you can do something to like to try to be more than 30 degrees. Like for example, if you could place like some people, they use like a ice pick and a hammer to make a hole before you start to drill, so that you won't skive too much with a larger angle. Yeah, if you can try to have some of this technical some method to overcome this the problem.
Thank you so much.
Thank you very much.
Yeah.
Other questions, please?
Yeah, I have a question. Thank you very much, Khoo, for a very nice presentation. So SECG is very new, or even not even being practiced in our hospital in Kuala Lumpur, Malaysia. So I have a couple of questions. Number one, what are the prerequisite or the investigation that you need, especially if you want to embark on the robotic implantation of the SEEG? Do we need any 3D CT scan, angio, whatever it is that you need to prepare before you can embark on that? So that's my first question.
Okay, so it's very important that we avoid vessels when we do SEEG, right? So usually what we do in our hospital is we do enhanced MRI, thin slice enhanced MRI, and also enhanced CT. So I'll do a CT angiogram and a CT venogram, both, and also enhance 3D MRI, T1. And I will use these three modalities to do my planning. Yeah, that's the least, at least what we have to do before this planning.
Okay, my second and third question is almost related. Number one, how long you keep the electrode for analysis before you make a decision to remove it? And the final question, you show that in your outcome, the SECG have shown much improvement in terms of outcome compared to subdural. So
Yes.
do you have any sub-analysis of which group of epilepsy? Is it temporal, frontal, eloquent that have a significant impact when you perform robotic SEEG?
So we go back to the second question first, right? Sorry, can you please remind me again?
The duration. How long you
The
keep
duration. Yes, yes.
electrode?
Usually, we keep. I would say the maximum we can keep is like not more than 2 weeks.
Okay.
But we can keep as long as we need to capture enough seizure for analysis. So, well, how long do you keep the patient with subdural grace, for example? Usually you keep like 2 weeks, right? So it's the same. It's almost the same, but we have the freedom to remove the electrode before the second week, because if we have like more than enough seizure in 1 week or 10 days, then we can just remove the electrode bedside, right? Yeah, so that's we have the freedom. So in our hospital, the average is around 10 days. Yes.
So what about the outcome? So which group actually shows a significant improvement?
So I didn't show in this presentation. I have the analysis done for. So as I can remember, it shows a better outcome for frontal.
Okay.
Of course, for temporal, we have less temporal cases now. Usually, they will not undergo intracranial recording, or most of them, they will just undergo subdural. So we have less people undergoing SEEG with temporal.
Okay, thank you very much.
Yes.
Thank you. Any other questions, comments? Professor Khoo, I have one question.
Yes, true.
Yeah.
But you know more than me.
Yeah, I know the hypothesis is very important for SEEG, but in clinical situations, there are some cases with very difficult to make a hypothesis.
Yes.
For example, a non-regional frontal lobe epilepsy, and the patient had no lateralized sign or some signs of localization. What should we do in that situation for the SEG planning?
Well, we have to be very, very careful if we should proceed with SEG in these cases. So, if we still believe that patient has a single focus, then we should try to get as much as possible. The simiology will drill the patient a lot and ask a lot of questions to get all the information that we can. And another thing is that, well, all the non-invasive study, I think we will need to really, really dig into them. Usually in our hospital, and I believe in Dr. Uda Hospital, we'll do at least FDG PET, we'll do MEG, and in my hospital, we do simultaneous EEG fMRI. We'll do as much as possible so that we can get as much as possible the information. And then when we look at this study, if all these non-invasive studies giving us like almost the same region, then we should go back again to the MRI, looking at more deeply into that region. Sometimes we do find very subtle lesion in those areas. Then if we have all these evidence, then I think we can proceed to SEG. But even if we do that and we don't get anything, then I wouldn't advise that we should proceed, right?
Okay, thank you. So thank you very much, Professor Khoo. So let's move on to the second speakers. Thank you very much. So I introduce Professor Hyun-sung Kim from South Korea. He will give us a lecture about spinal surgery, endoscopic surgeries. So please start your lecture, Professor Kim.
Okay, thank you so much for introducing me. Okay, can you see my slide?
Yes. So please,
Okay.
yeah.
Okay, thank you so much. Thank you so much for invitation. It is my great honor to give a talk in the ISMINS ACNS ISMINS webinar. I'm Hyun-sung Harrison from Harrison Spin Arches Hospital, Cheongdam, South Korea. And currently, I'm a president of Korea Minimal Invasive Spine Surgery Society and editor-in-chief of a Journal of Minimal Invasive Spine Surgery and Techniques. Today, I will give a talk about that importal spinoscopic decompression for degenerative spinal disease. I'm majorly doing the importal spine surgery because of that. Today, I will talking the importal endoscope decompression. I have starting endoscope decompression about 10 years ago, and I have about 5,000 cases of endoscope decompression for lumbar cervical and thoracic. Today, we will discuss about that. Yes, we know that some in the initial time of the spinal surgery, it looks like a very big surgery, and because of that, there have so complication and related problems after operation. To solve these problems, spinal surgery developed firstly microscope-assisted open surgery, but still, in spite of that, using the microscope, there still have some complications of that related to the operation. To decreasing this problem, the minimal invasive spinal surgery, especially using the tubular retractor, developed in the 21st century. And some things of problems is solved after using this process, but still there have unsolved problems still remain there. Because of that, doctors they try that more minimized option of the endoscopic spinal surgery, and also endoscopic spinal surgery developed by 4 generation. Among them, third generation is the endoscope decompression using the unipolar and bipolar. After endoscope decompression, the spinal surgery of the endoscopic spinal surgery developed so much, and currently with the development of 4th generation of the endoscope fusion surgery, now we about 90, more than 95% of degenerative disease by solved by the endoscopically. And mostly the pathology that need the decompression usually can pass solved by the endoscopically. And but at the initial time, some doctors worry or question about that. What is the advantage of the endoscopic spinal decompression rather than the conventional tubular or minimized option of endoscopic decompression? But currently, we know that the real advantage of the endoscopic decompression is it can possible more deeper point more clearly, and also more mobile, and mobile meaning that we can approach more deeper point more easily using the mobilization of the working channel. Because of that, we can manage the more detailed point of the remained point, and some very difficult point of the endoscope decompression pathology that need spinal stenosis that need decompression pathology. Because of that, now or many doctors they agree that the advantage of the endoscopic decompression also real rationale of the endoscope decompression you can see here is that some this preoperative and 1 day after operation you can see the real we hope to decompress more sufficiently, but we hope to preservation of facet, but we hope to preserve the muscle, but we hope to take a good result to the patient, but that is possible by the endoscopic eye. You can see like this here, but uh, because of that, nowadays we can give the real good result to the patient like this. And also in the endoscope decompression, in the anatomically, we see know that there's some inner layer of the ligament flavum and outer layer of ligament flavum. But we should remember of inner layer of ligament flavum of the cranial tip and the caudal tip. Then we can give the sufficient decompression can take it. And also some anatomical variation maybe from the lower level and upper level that need a checking. And also in the endoscopic unipolar approach, it can possible approach two approach technique of the laminar point technique and so medial border facet joint approach. But I use this B of the medial border facet because there is more deeper and there is more easy to control the bleeding. And also then in spite of that, the endoscope decompression, there have searching the anatomical landmark is not easy because of that. Some configuration is not easy in the endoscope view. But if you keep in mind that the 3 V point of the inferior articular process and lamina making like this V shape, and middle of the cranial tip and middle of the caudal tip make like this V shape that can make some landmark of the anatomy and can over the contralateral side. And but in the you should keep in mind that this my comment is that in the endoscopic decompression there have 2 important points of that approach. One is the some under the top and over the top. We know that Dr. Siepe and me are already talking that the over the top technique. Under the top technique meaning that firstly insert the punchy under the ligament flavum, that limbar of the ligament flavum. But over the top meaning that firstly drilling the contralateral side and or expose the ligament flavum, then finally take out the ligament flavum is that over the top. But another important approach consideration is that inside out and outside in. You can see inside out meaning that firstly insert the working channel, punch it to the center of the ligament flavum and take out the limbar of the ligament from the outside. But outside in meaning that firstly drilling the all around the structures of the lamina around the ligament flavum, then finally take out the ligament flavum by the one piece. This outside in. This clarification of these two approach technique is very important in understanding the endoscope decompression. And then also using this outside in over the top technique, you can see like this butterfly ligament flavum relaxation is possible. And also using over the top outside in approach, keeping this technique is very important, not only lumbar spine, but also thoracic and cervical. You can see like this over the top contralateral and take out the ligament flavum by the one piece and outside in over the top technique. And this technique a similar application to the thoracic and cervical. You can see my paper of that. Cervical thorax also same with some outside in over the top, and then cervical also same with the outside in over the top like this, and drilling of the around the structures, and finally take out the ligament flavum by the one piece. Then is a key of the safety preservation, keeping the safety of the cervical spine and thoracic spine. Biomechanically, fortunately, in the biomechanically, endoscopic decompression of lumbar, cervical, and thoracic has two distinct characteristics. Is that firstly, it preserves the tensegrity, meaning that preserving the all structures of the muscle, ligament, and the skin and all structures. And second, characteristic. Typical characteristics is that you can see here that some remodeling is very good in the thoracic and here cervical area. Because of that, these two typical characteristics of the tensegrity and remodeling, in the endoscopic decompression of lumbar and cervical and thoracic, usually instability not happen, aggravation is not so easy. I already published this result to the paper, operating neurosurgery practice, and like this. And also in the surgically, we there have some preparation of a not so small but also a larger scope, and also there is a very good drill system and very good RF and radio frequency ablation system. I naming this is a soft tissue management system and hard tissue manipulation system. With using this equipment preparation, we can try the endoscope decompression, and there have some fluid irrigation system that setting needed like this. And then also we can apply the over the top outside in over the top technique. We can apply it like that. And this technique I've already published in the World in Neurosurgery 2016, like this. And also this technique, also this is my another paper of neurospine. You can see the steps of the 12 steps of effective endoscope decompression of the over the top outside in approach. And the main concept is drilling around the structures like this. And then we can approach it like this, and sometimes can go to the contralateral frame like this way. And these procedures of the firstly, you can see the some outside in ligament problem drilling and expose the midline and the contractor outer ligament problem splitting and expose the cranial tip of V point and caudal tip of the V point and the final take of the ligament from there. Then you can see like this way. Yeah, these procedures, yeah, ducking and drilling, contractor, cranial caudal, and detach the ligament flavum and the final take out the ligament flavum like by the one piece like this way. And also just similar to the king and then drilling of the cranial, ipsilateral cranial and the caudal, and now go to the contralateral side. You can see this video in the neurospine. And then finally take out the ligament flavum, then we can see the final endoscopic decompression, and after operation you can see like this way. And then because of that endoscopic decompression, you can keep in mind that the checking the 3V point and detach the cranial and caudal ligament flavum and sublaminar drilling sufficiently than needed. And sometimes you need some channel in channel or channel switching technique using the big, larger scope and small scope is possible. And like then go to the contractor frame and extra foraminal approach is possible. And thorax, I already mentioned that the same way of the like this drilling firstly like this way and finally take out the ligament flavum by the outside and over the top approach. Then possible sometimes single level decompression, separate double level decompression, and conjoin the double level decompression is possible. And also cervical also same is the some over the top contralateral over the top outside and over the top technique, and then firstly drilling around the structures and finally take out the ligament flavum like this way. And also there have several techniques that decompression in the cervical area. Then you can see like this cervical decompression here and thoracic decompression like this way is possible. And also finally we can take out the lumbar butterfly resection and thoracic butterfly resection, and this 3-level cervical butterfly resection is possible. 3, 4, 4, 5, 5, and 7 by the one piece resection is possible. I will show the some of cases. We can see the some 2, 3, 3 spinal stenosis cases, and after same method, and we can see the expose the cranial tip of the ligament flavum and cutting some part of that. There have finally take out the ligament flavum, then you can see the decompression here. Then you can see the decompression is sufficient. This is very simple. But this case is 80-year-old female patient with a very severe cases. But in like this case, severe cases usually some doctors is not indication of stenosis, but using the outside and over the top technique, this is can possible and can take excellent clinical result. You can see the drilling here and take out the ligament flavum by the one piece, and after that you can see like this result. And also this technique applied to the some combination of the disc ring bar is possible. And sometimes like this 2-level, 3-level cases you can see after operation can take excellent clinical result. Also, fast assist also very good indication of the endoscope decompression, but in the contralateral approach usually than needed. And also this case is 4-level stenosis cases pre and post-operative. And also finally, you can see the all decompression and operation time is a maybe 1 hour 30 minutes maybe 4-level, and after operation you can see the 2 small skin incision for this 4-level decompression. I think that this 75-year-old male patient. And also in the cases, sometimes we can possible central decompression, contralateral, lateral recessive, Freeman, extra Freeman decompression is possible using the channel switching technique. After decompression of central and change the small scope and go to the contralateral Freeman, resection of contralateral SAP, and then resection of ventral parts of the Freeman, then we can go to the contralateral side like this way. And also in the thoracic, I already mentioned that it can possible by the over the top outside in approach is possible. For example, you can see here the some already drilling here and sorry here this midline maybe and take out the ligament flavum, calcify the ligament flavum, and then finally remove the contralateral side calcification like this way. And after operation, you can see like this. This already patient followed the more than 5 years. The patient take an excellent clinical result. And also in the myelopathy cases also can take a same technique is possible, and also the patient can take excellent clinical result because of that. This really some outside in all the type technique, meaning that some near not touch the dura are called myelopathic point during the operation, and the final take out the count from only. And also you can see like this combination of the thoracic myelopathy with the disc pathology, or also possible firstly decompression, after then change the small scope and remove the disc pathology together, then after operation you can see like this result and the patient. And also this case is some stenosis with a calcified ventral portion of disc pathology, also can possible by the endoscope decompression, and then also change the source scope. We can operate to the ventral portion of the calcified disc area like this way. Then you can see the like this result. This patient first visited me with some weakness, and after 6 months later, the patient walking is possible, and also the result also very excellent clinical result can take. Also, this another patient with the myelopathy of the thoracic cases, also decompression with the outside and over top, and the first day before operation, and 1 day operation, 2 day operation, 3 day operation. The patient discharged with the walking by herself. And 6 months later, the patient motor recovered completely, like this way. And also this outside and over top rumor of the ligament problem applies same in the cervical area. You can see these cases with some stenosis myelopathy cases, and after operation, it decompresses very nice. Oh, okay. Time is not so much, not so good. Okay. And this another cases with cold injury cases came with me with some weakness, and after operation, you can see the patient, the motor weakness solved, recovered, and 6 months later. And this another cases is myelopathy cases with some calcified disc, and we decompress this posterior part only using the one block resection over the top outside in technique. After then you can see decompression. And another cases of myelopathy cases also decompressed like this way. And 6 months later, the patient take excellent clinical result. This another cases with the myelopathy case weakness. With the weakness after operation, the patient weakness improves so much, and also they have no additional injury in the cord. And also these another cases of the two-level myelopathy cases, and also you can see preoperatively and postoperative, and 1 year later, the patient result is very excellent, nice. This is three-level myelopathy with stenosis cases, and also after operation, and 1 year, 6 months, and 1 year result. The patient result is excellent. This another case is with the myelopathy. The patient with visited me with some weakness, but after operation, you can see here the sufficient risk decompression is possible. There have no instability and hypothesis aggravation is not happen there because of that. There have a good tensegrity still remained and some remodeling of bone structures after operation, after some later. And also this another cases of 3, 4, 4, 5 myelopathy with some weakness patient also with me and after operation. And this another case is also some cold injured patient with me, and also this patient with me with the weakness and walking disturbance, and after operation, and 6 months later, the patient motor recovered completely, and you can see here the like this decompression here. Yeah, sometimes this patient forever stenosis with some weakness, but the patient is a renal failure patient. Because of that, I tried endoscope decompression, and after operation, the patient take excellent clinical result, and the patient also can possible walking is possible. Rehabilitation also possible, and also you see the 3D CT, the posterior cervical decompression done very nicely. In conclusion, currently in the degenerative spinal stenosis that need a decompression, mostly can possible decompression by the endoscopically, by the uniportal, sometimes biportal is possible. Because of that, I hope you should learn the endoscopic spine surgery. And also, I published this paper maybe 2023 with some special issue of the old neurosurgery by the special issue of the endoscopic spine surgery. That time, I'm talking that my editorial comment is that there is nothing in the world that does not change. Please try and new things. And I hope to I will have this year November the Communist International and World Spinoscope Congress of the Endoscopic Spine Surgery. I hope to join you. Thank you so much for your kind attention.
Thank you very much, Professor Kim. A beautiful presentation. Okay, so does anyone has comments or questions for this presentation? So in uniportal endoscopy, we can see a much wider and deeper area than I expected. So do you always use a uniportal technique, or you select the uniportal or biportal or open surgery in depends on the situation?
I performed endoscopic spine surgery more than 25 years, and also I believe that some real concept of endoscopic spine surgery started from uniportal. Because of that, as a leader of the endoscopic spine surgery, I always keep the uniportal only. I think that the biportal is also good, but really in the scientific basis, biportal surgery never overcome the uniportal if that mastered completely. Because of that, some leaders should mastering in this uniportal area. I perform these procedures.
Yes, thank you. Any other questions, comments?
Professor Kim, excellent presentation as always. So I have
thank you.
two questions. Number one, with your uniportal approach, if you have a multiple degenerative disc, how many level you can go safely with one incision?
We can possible by the one skin is possible, 3 level and 4 level is possible, but sometimes in spite of the small skin is usually making the some approach angle, some deviation is so serious. Because of that, for beginner, that is very risky to the dural tear and some incomplete surgery. Because I always recommend the 2 level by the one skin incision.
Okay, thank you. Second question is related to complication. Because you have a long experience and it shows it's very easy to do. But one of the difficult complication which is preventable is CSF leak. Especially you have a severe stenosis and thickened phlebum. And what is your advice or strategy that if you to prevent this dura tear, and if you have a dura tear, how do you manage it?
Yeah, I already mentioned that some using the outside in over the top is some first choice to preventing the dural tear decreasing. But anyway, during the process there have so serious adhesion or some unchecking point of deepest point making sometimes dural tear. But it happened immediately. It apply the taco seal. Do you know taco seal?
Yeah, okay.
There is very easy to control the dural tear point. But if they have a big dural tear, they need a direct conversion to the open surgery.
Okay, all right. Thank you very much.
So one question
Right.
from listeners. Can you see the Q&A box? Excellent presentation. In the case of complications like dural tear, what is your advice?
We already asked from Ajmi Alias, and yeah, but in the beginner, the dural tear happen very easily in during the endoscopic spinal decompression, especially some during the punchy. That is very risky because of that. I always already mentioned recommendation that some inside out is some very higher chance of dural tear during the punch process because of that. It need some learn the outside in drilling technique. But if you doing the inside out, it need a very slowly doing the decompression process.
Thank you.
Yes, thank you for your wonderful presentation, Professor. I'm very proud to learn from you again. I have a question as a medical student. So, your outside in over of the top technique allows decompression without destroying the posterior tension band. Do you think this approach is actually closer to functional spinal surgery rather than traditional structural surgery? Thank you.
Dr. Mara, we met before 2 days ago.
Yes.
Yeah, yeah, really, in the cervical and thoracic and lumbar, I already mentioned that I have more than 5,000 cases of lumbar and or the decompression, endoscope decompression pressures. And at the initial time, I was so worried about that some so much drilling and the removal of the structures, there may be some making the instability and some aggravation of kyphosis. But yeah, but the result is completely different. In spite of cervical area, sometimes I complete resection of facet due to my fault. But after the patient have no aggravation instability, after then, rather than the patient remove the 2 years later completely, it means that in the cervical, in the endoscope decompression, first point of the surgery is that not keeping the functional instability, rather than the firstly point is that the sufficient decompression is first. Dr. Maram, can you understand?
Yes, I understand.
Yeah.
Yes, I understand. Thank you.
Okay, we have another question from in Q&A box. Doctors from Kojima doctor.
Kojima.
Thank you for can I ask the both monopolar? Can I ask that does your hospital use both monopolar and bipolar devices? How do you usually decide which one to use?
I think that maybe Kojima asking about the unipolar or bipolar. But unipolar and bipolar talking that the radio frequency system, ovulation system. But I think that Kojima asking about the unipolar and bipolar. But in my clinic, I'm only keep the unipolar. And I work my brother with the Dr. Ho. He only keep the bipolar. He also very famous bipolar surgeon in the world. But Dr. Ho and me always collaboration. But the indication is the same. Understand? But only some cases of transformer approach that need cases Dr. Ho send to me. But another or cases by themselves, not engage each others.
Maybe
Meaning
he
that
want to ask. Maybe he want to asking monopolar devices and bipolar coagulation system.
I don't know. But in the endoscopic spinal surgery, yeah, he already answered. I see. I think that he talking that the unipolar and bipolar, monopolar and bipolar.
Okay, thank you. Any
May
other
I ask
question?
more?
Yeah.
Yes, I have one. You strongly, Professor, advocate in block removal of the ligamentum flavum. From physiological perspective, does spicemal removal increase micromotion of the card compared to in block resection? And could this explain your lower complication rate? Thank you.
Yeah, in the endoscope decompression at the initial time, I'm also experienced that there's some incomplete surgery, and also, unfortunately, there is some more higher in the inside out technique because of that some attachment of the ligament problem of the cranial on the point, and some caudal on the point is very not easy. Only some scratch from that area, but because of that, uh, one block resection is very important key to resection of all area from the cranial tip of the ligament problem and caudal tip of the ligament problem. Because of that, in the can possible only after only expose the cranial tip and caudal tip of the ligament problem and the ipsilateral and contralateral ligament problem cutting. After then, it can take out the ligament problem by the one piece butterfly resection is possible. Because of that, keeping the butterfly resection technique is very important in endoscopic decompression. Madam, understand?
Yes, thank you. Thank you.
Yeah, thank you very much, Professor Kim.
Yep.
Any other
It's okay.
question? Yeah, so it's almost the time to close.
Yeah. Professor, I'm talking that I mentioned that some unipolar is some more higher, more superior in the scientific basis, but I always love the bipolar together because of that. We still don't know that some what is the our real rationale to start process advancement of this procedure is to serve the good clinical result to the patient. Because of that, I'm always agree that learn the endoscopic spine surgery sometimes by unipolar and sometimes bipolar, and give the good result is more good rationale rather than the unipolar or bipolar. Thank you so much. Yeah.
Yeah, thank you very much, Professor Kim.
I want yes, I'm grateful for the opportunity to contribute and to be part of such exceptional academic environment. Thank you very much, and thank you for Professor Yoko Kato and ACNS for allowing young students like me to learn from the most distinguished neurosurgeon in the world. Thank you.
Thank you very much. Yeah, it was my great honor to host this webinar. So thank you again, Professor Kim and Professor Khoo. So close the session. Thank you very much.
Thank you so much. See you soon.
See you.
Everybody,
Thank you.
Thank you.
everyone.
ありがとうございます。
Bye.
Hi,
Thank you.
how are you?
Bye.